want to tell you about a patient I'll call Carol, 71 years old, retired schoolteacher, taught English literature for 34 years. She could recite entire passages from memory. Her husband called her his walking encyclopedia. Then, over about 14 months, something changed. She started losing words mid-sentence. She forgot appointments she'd written down. She got confused driving home from church, a route she had driven every Sunday for 19 years. Her family took her to a neurologist. The word Alzheimer's was spoken in that room. Her daughter called me devastated. Here is what I need you to hear. Carol didn't have Alzheimer's. Carol had a medicine cabinet. And when we carefully reviewed every single pill she was taking, Carol started coming back. My name is Dr. Emily Carter. I'm a surgeon with over 20 years of clinical experience. And the reason I'm making this video today is because what happened to Carol is not rare. It is not unusual. It is happening right now in homes across this country, to people whose families believe they are watching their loved one disappear. Today, I'm going to walk you through 9 of the most commonly prescribed and purchased medications that research now links to accelerated cognitive decline after 60. Some of these will shock you. Several are sitting in your medicine cabinet right now. At least one is sold over the counter and marketed as completely harmless. Stay with me through all 9, because number 1 is not a single medication at all, and it is the most dangerous thing on this list. Before we begin, one important thing. I am not telling you to stop your medications. Please do not do that without your physician's guidance. What I am telling you is this. You have every right to understand what is entering your body. You have every right to ask questions, and you have every right to protect your brain. Knowledge is not dangerous. Silence is. Let's get into it. Medication number 9. Diphenhydramine. Benadryl, PM sleep aids. Medication number 9. And I want to start with a question. Do you have a small bottle of Benadryl in your nightstand right now? Or a box of Z-Squil, Tylenol PM, or Advil PM? If the answer is yes, I completely understand why. It's inexpensive. It's over the counter. It says sleep aid right there on the label. It feels like the sensible, harmless choice. Here is what that little pink tablet is actually doing inside a brain over 60. Diphenhydramine belongs to a class of drugs called anticholinergics. Remember that word. It will appear throughout this video. Anticholinergics work by blocking a neurotransmitter called acetylcholine, your brain's primary chemical messenger for forming memories, maintaining focus, and staying alert. When you're young, your brain has acetylcholine to spare. When you're over 60, you're already working from a lower baseline. Block even more of it nightly with diphenhydramine, and the cumulative damage is measurable. A landmark study in the Journal of the American Geriatric Society found that regular users of diphenhydramine faced substantially elevated risk of cognitive decline, with visible shrinkage in memory-related brain regions confirmed on neuroimaging. And the hidden danger? It's tucked inside dozens of products labeled PM, nighttime, or sleep formula. If you see any of those words, diphenhydramine is almost certainly in it. What to do instead? For allergies, ask your doctor about second-generation antihistamines like loratadine or cetirizine. They do not cross the blood-brain barrier the same way. For sleep, safer options are coming later in this video. Medication number 8. Proton pump inhibitors, PPIs. Medication number 8. And this one frustrates me more than almost any other on this list. How many of you were told years ago that you needed a daily acid reflux pill and have been taking it every single morning since, without anyone ever suggesting you try to stop? Proton pump inhibitors, PPIs, are among the most overprescribed medications in the world. Most were designed for 8 to 12 weeks of use. Millions of people have been on them for years, decades. Here's the problem. Your stomach acid doesn't just cause reflux. It also performs a critical function. It extracts and absorbs vitamin B12 from your food. And B12 is not optional for your brain. It is essential. B12 deficiency is clinically linked to memory impairment, depression, nerve damage, and a pattern of cognitive decline so similar to early Alzheimer's that the two are routinely confused, even by experienced physicians. A 2016 study in JAMA Neurology examining over 73,000 adults aged 75 and older found that long-term PPI users carried a 44% higher risk of developing dementia compared to non-users. But more alarming, research now suggests PPIs may accelerate the accumulation of amyloid beta plaques in the brain, the same toxic protein deposits that define Alzheimer's disease. We are not just talking about a vitamin deficiency. We are potentially talking about a direct molecular pathway to neurodegeneration. What to do? Talk to your doctor about tapering using H2 blockers as a bridge. Dietary changes, smaller meals, no late-night eating, elevating the head of your bed can dramatically reduce reflux naturally. And if you remain on PPIs long-term for genuine medical need, have your B12 and magnesium levels tested regularly. If you're still with me and finding this important, go to the comments right now and type the number 8. That's all. Just the number 8. It tells me you're watching. It tells me this is reaching the right people. And if you haven't subscribed yet, do it now. I post every single week, and this is exactly the kind of video your doctor doesn't have time to sit with you and explain. Let's keep going. Medication number 7. Bladder control medications, oxybutynin. Medication number 7. And this one genuinely upsets me. Not because of the medication itself, but because of how little patients are told before they take it. Overactive bladder is a real and deeply disruptive condition. It affects sleep, it causes embarrassment, it impacts quality of life. When a physician hands you a prescription for oxybutynin and tells you it will help, of course you take it. That is the reasonable thing to do. Oxybutynin is one of the most potently anticholinergic medications in common clinical use. It doesn't just act on your bladder. It crosses the blood-brain barrier with remarkable ease and directly disrupts the same acetylcholine systems responsible for memory, learning, and recall. Research has shown that the hippocampus, your brain's primary memory center, demonstrates measurable physical volume reduction in long-term anticholinergic users. Not just mental fog, actual structural brain change. A comprehensive 2019 study published in the British Medical Journal found that seniors using strong anticholinergic medications like oxybutynin for more than 1 year faced a 49% higher risk of dementia diagnosis, nearly 1 in 2. What to do? Ask your urologist about mirabegron, a newer bladder medication that works through an entirely different mechanism and carries dramatically less cognitive risk. This single conversation could change everything. Medication number 6. Benzodiazepines. Medication number 6. And I want to handle this one carefully because I know how many people in this audience have a deep and complicated relationship with this medication class. Benzodiazepines, Valium, Xanax, Ativan, Klonopin have genuinely helped millions of people through panic disorders, severe anxiety, and devastating sleep conditions. I am not dismissing that. What I am asking you to do is hear the science without defensiveness. Benzodiazepines work by amplifying GABA, your brain's natural calming chemical. They produce rapid, powerful short-term relief. The problem is what happens when that mechanism stays switched on for months or years. A 2022 study tracking over 8,000 seniors across 6 years found that those who used benzodiazepines for more than 3 months carried a 51% increased risk of Alzheimer's disease. The risk was highest for long-acting formulations like diazepam, which accumulate in fatty tissue, including brain tissue, over time. Here's the biological explanation. When GABA is chronically overactivated, your brain begins reducing its own natural responses. Neuroplasticity, the brain's ability to form new connections, adapt, and learn, deteriorates. Memory encoding slows. The brain, being calmed, gradually loses its capacity for dynamic function. And the trap, stopping, is brutal. Rebound anxiety and insomnia can be far worse than the original symptoms, making the drug feel necessary even as it causes the damage. Critical warning: never stop benzodiazepines abruptly. Work with your physician on a slow, supervised taper. Alternatives include buspirone for anxiety, cognitive behavioral therapy for insomnia, and in some cases, low-dose melatonin or magnesium glycinate. Medication number 5, statins. Medication number 5, and I want to be precise here, because statins save lives. Cardiovascular disease remains the leading killer of adults over 60. For many patients, statins are entirely appropriate and genuinely necessary. But here is what your cardiologist may not have mentioned. Your brain is composed of nearly 60% fat. Cholesterol, despite its reputation, is not the villain in the brain. It is a structural necessity. It forms the myelin sheath around your nerve fibers. It is essential for synaptic function. Without adequate cholesterol, your neurons struggle to communicate. The FDA updated statin labeling in 2012 to include warnings about memory loss and confusion, a relatively rare acknowledgement issued after reviewing thousands of adverse event reports. A 2023 analysis in Frontiers in Aging Neuroscience found that adults over 70 using high-dose statins for more than 3 consecutive years showed measurable increases in mild cognitive impairment compared to non-users. Here's the important distinction. Not all statins carry equal cognitive risk. Lipophilic statins, like simvastatin and atorvastatin, cross the blood-brain barrier more readily. Hydrophilic statins, like pravastatin and rosuvastatin, show significantly less cognitive impact in comparative research. What to do? If you're experiencing brain fog or memory changes on a statin, ask your doctor whether switching to a hydrophilic statin might provide equal cardiovascular protection with less cognitive burden. Also have your CoQ10 levels checked. Statins deplete this compound, which is critical for cellular energy in the brain. Medication number 4, amitriptyline. Medication number 4, and this is the one that surprises people most consistently, because it is almost never prescribed for depression anymore. Amitriptyline is an old tricyclic antidepressant that has been repurposed over decades for nerve pain, chronic migraine prevention, fibromyalgia, and sleep. Physicians sometimes specifically choose it because it causes sedation, using the side effect as a feature. Here is why it is uniquely dangerous for older brains. Amitriptyline is one of the most potently anticholinergic medications still in widespread clinical use. Its ability to block acetylcholine receptors is extraordinarily high, higher in fact than many medications specifically designed as bladder drugs or antihistamines. A landmark 2015 study in JAMA Internal Medicine examining over 3,400 adults aged 65 and older across a 10-year period found that high cumulative anticholinergic exposure with amitriptyline among the top contributors, was associated with a 54% greater risk of dementia. What makes this particularly difficult is the invisibility of the damage. There is rarely a dramatic moment of decline. There is just a slow, quiet erosion, word-finding difficulties, problems with sequencing, and inability to hold complex thoughts, attributed entirely to normal aging, while the medication is never once questioned. Alternatives, duloxetine or gabapentin for nerve pain, carry far less anticholinergic burden. For mood, modern SSRIs are significantly safer for aging brains. Ask your physician directly about transitioning. Medication number 3. Antipsychotics. Medication number 3. Pay very close attention here. What I'm about to tell you happens every single day, in nursing homes, memory care units, and hospitals across this country, and most families never find out. Antipsychotic medications were developed for serious psychiatric conditions: schizophrenia, bipolar disorder with psychosis. They are powerful, brain-altering drugs with significant side effect profiles. Today, they are routinely prescribed off-label to elderly patients who are simply confused, restless, or agitated. Not because they have psychosis, because they are difficult to manage in an understaffed environment. The FDA issued a black box warning about this practice over a decade ago, citing increased risk of death in elderly patients with dementia-related behaviors. The prescriptions have continued. Antipsychotics work primarily by suppressing dopamine, the brain chemical linked to motivation, movement, memory consolidation, and executive function. Chronic dopamine suppression in an aging brain produces flattened emotion, slowed thinking, and accelerated neurodegeneration. A 2022 study in The Lancet Healthy Longevity, tracking more than 25,000 older adults, found that seniors given antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even with no prior dementia diagnosis. What to do? If a loved one in a care facility is being prescribed quetiapine or risperidone for reasons other than documented psychosis, ask why. Ask what non-pharmaceutical behavioral interventions have been attempted. Ask what the plan is to stop. You are entitled to those answers. Medication number 2. Paroxetine Paxil. Medication number 2, and this one receives nowhere near the attention it deserves. Paroxetine, sold as Paxil, is classified as an SSRI, the same family as Prozac, Zoloft, and Lexapro. When people hear SSRI, they think modern, safe, well-tolerated. And for most SSRIs, that is accurate. Paroxetine is the exception. Unlike every other SSRI, paroxetine carries significant anticholinergic activity. That one pharmacological detail separates it entirely from its siblings. While Zoloft and Lexapro leave acetylcholine largely undisturbed, Paxil interferes with it in a way that closely resembles the older tricyclic antidepressants. A comprehensive 2021 review in Frontiers in Psychiatry found that elderly patients on paroxetine showed measurable declines in short-term memory and verbal recall within the first year of treatment. Declines not observed in patients on other SSRIs at comparable doses. The American Geriatric Society has placed paroxetine on their Beers criteria, the official list of medications considered potentially inappropriate for older adults, specifically for this reason. What to do? If you are over 60 and currently taking Paxil, ask your physician whether transitioning to sertraline or citalopram might provide equivalent antidepressant benefit without the anticholinergic cognitive burden. Most patients transition successfully with careful, gradual tapering. We are almost at number 1. And I told you from the beginning, It is the most important thing in this entire video. Before we get there, if this has been helpful so far, please share this video right now. Not after, right now. Send it to a family member, a friend, someone you love who is over 60 and takes multiple medications. You may be the reason they finally get the answer they've been looking for. Medication number 1, anticholinergic polypharmacy. Medication number 1, and as I promised, it is not a single drug. Every medication on this list, taken alone, may produce only mild cognitive effects in some people. A little more forgetfulness, a little more fog. Easy to dismiss, easy to attribute to getting older. Here is what happens in the real world. The average American over 65 takes 4 or more prescription medications daily. Many take 6, 8, 10 or more, a combination of prescriptions, over-the-counter products, and supplements, often prescribed by different doctors who have no visibility into each other's decisions. When several of those medications carry anticholinergic properties, they do not simply add together. Research suggests they compound, multiplying each other's effect on the aging brain. A 2022 analysis in Age and Aging, tracking over 280,000 older adults, found that those with the highest anticholinergic burden had a 120% increased risk of developing dementia over a 10-year period, double the normal risk. From pills that almost none of them had ever been warned about in terms of cognitive consequences. Let me make this real. Imagine a 72-year-old woman named Dorothy. She takes a PM sleep aid every night. She takes oxybutynin for her bladder. She was recently prescribed amitriptyline for foot pain. And she takes an over-the-counter heartburn pill every morning. 3 of those 4 are anticholinergic. Each one, according to her separate prescribers, is appropriate and safe. Together, her anticholinergic burden may be in a range clinically associated with serious dementia risk. And not one doctor, not one pharmacist, has done the math on her behalf. This is not a hypothetical. This is Dorothy. This is Carol. This may be your mother, your spouse, your neighbor. And the most heartbreaking part is that drug-induced cognitive decline is frequently reversible. When the medication burden is identified and systematically reduced under proper medical supervision, the fog can lift. Memory returns. Personality reemerges. Your brain is not passive. It is adaptive, resilient, and capable of healing when given the conditions to do so.
Action plan. Here is exactly what I want you to do, starting this week. Step 1. Write down every single thing you take. Prescriptions, over-the-counter products, supplements, sleep aids, pain relievers, every single one. Step 2. Search the Anticholinergic Cognitive Burden Scale, the ACB scale. It is free, publicly available online. It scores medications by their cognitive risk. Look up every item on your list. Step 3. Schedule a medication review with your primary care physician. Use those exact words. I'd like a medication review to assess my anticholinergic burden. A good physician will appreciate the advocacy. Step 4. Ask specifically about deprescribing, the intentional, supervised process of tapering off medications that are no longer necessary or carry unacceptable risk. It is a legitimate and growing field of geriatric medicine.
Step 5. If your concerns are dismissed, seek a second opinion. A geriatric pharmacist can also perform a comprehensive medication review. You are not being difficult. You are being responsible. Before you go, I want to say something directly. If you watched this video and recognized Carol in someone you love, a parent, a spouse, someone whose personality has been quietly disappearing, please do not carry that alone. Drug-induced cognitive decline is not a death sentence. It is not inevitable. It is not always what it looks like. I have sat with patients whose families had already started grieving, and I have watched those same patients come back because someone asked the right question at the right time. You are that person now. You watched this video. You have the information. And the most powerful thing you can do with it is not keep it to yourself. Share this. Ask the questions. Advocate for yourself and for the people you love. Your brain is worth protecting. And now you know exactly where to start. One final question before you go. Which of these 9 medications are you or someone you love currently taking? Drop it in the comments. Just the number, 1 through 9. Or type yes if you recognized your own situation somewhere in this video. I read every single comment. Everyone. If this helped you today, share it. Post it on Facebook. Text it to a family member. The person who needs this most is probably not going to search for it on their own. You might be the reason they find it. I'm Dr. Emily Carter. Stay sharp, stay informed, and I'll see you next week. Medical disclaimer. The information presented in this video is strictly for educational purposes and does not constitute medical advice. It does not establish a doctor-patient relationship and must not be used as a substitute for professional medical diagnosis, treatment, or guidance. Never stop, reduce, or change any medication without consulting your physician or qualified healthcare provider first. Stopping certain medications abruptly can be medically dangerous. Always work with a licensed medical professional before making any changes to your health routine. Scientific understanding evolves, and content reflects knowledge available at time of production.